Welcome to the patient education session for the lung transplant program. Today we will go over a large amount of materials, some of which may be new to you and some of which may be a review. If at any point any of the information reviewed is confusing or you have questions, please pause the video, write your questions down, and the questions can be addressed when we reconnect once this video is complete. The next few slides, I will review the members of which make up our lung transplant team. Some of these names may seem familiar and some may be new to you. On this slide, we have our transplant coordinators. As you are likely already familiar with us, Caitlin Daly and myself, Leah Lasota, are the pre-lung transplant coordinators. As pre-coordinators, that means from the point you were referred to lung transplant up until the point you are transplanted, we are your point of contact. Once transplanted, you will begin to work with the post-transplant coordinators, Edith Martinez and Kirsten Bilite. Here we have a slide of our many wonderful physicians that make up our transplant team. Depending on your disease process, you may or may not work with all of them, but for the sake of this video, I will review all of them with you. It is important to familiarize yourself with their names since they are on a rotating schedule. That means at the time you get called in for your transplant, there is a chance that any of these physicians could be caring for you. These physicians include Dr. Ba, Dr. Guzzi, Dr. Jablonski, and Dr. Sui. On this slide, we have our transplant surgeons. You may have already met with Dr. Song or Dr. Madariaga and already be familiar with them. They will be your implanting surgeons. Dr. Onsager is also a part of our transplant team and is an expert at lung procurement. The day you get admitted to the hospital, you will fill out a consent form. On that form, it will list the surgeons' names that will be present during your time of transplant surgery. Our advanced practice nurses, or APNs, are also a major part of our team. Our APNs include Cynthia Serduk and Rasmin Shivji. You may or may not have already met with our APNs during clinic visits with your pulmonologist, as well as during any inpatient stay you may have had. If that is not the case, then note that you will become more familiar with them either in future clinic visits or during your hospital stay after transplant. Additional members of our team, whom you have likely already met with and will continue to work with throughout your transplant journey, include Lisa Potter, our pharmacist, Fran Hammond, our social worker, Mary Ellen, our dietitian, and Ashley Harris, our patient access specialist. The next few slides will review the general selection criteria in which the multidisciplinary team utilizes to determine if transplant will be a benefit to a patient. As you already know, in order to be a lung transplant candidate, you're required to go through a battery of tests. Based on your results from these tests, our team will determine if you are an appropriate candidate for lung transplant. The results of these tests are important because our team wants to ensure that you, the patient, are sick enough to need a lung transplant, but also healthy enough to recover and be discharged from the hospital post-operatively. One major criteria to be on the transplant waitlist is that you must have severe end-stage lung disease. In transplant, one of the first things that are examined for our pre-transplant patients is whether there are any other therapies that they have not tried yet for their advanced lung disease that may be able to improve their symptoms and quality of life without getting a transplant. This is because one of the indications for transplant is that end-stage lung disease has progressed despite maximal surgical or medical therapy. So much so that it would be predicted that your life expectancy is less than 2 years. Another criteria is that patients must be free of other end-stage organ failure. The team can determine this from the results of the tests that you have performed thus far. For example, the heart catheterization and echocardiogram results show the team that your heart would continue to work properly throughout the surgery as well as post-operatively. If the results of the tests do not demonstrate that, and the team is concerned about another major organ, then the transplant team may determine that the organ transplant may be more harmful than helpful to you, in which case they would recommend that you are no longer a candidate. The reasoning for this testing is because the transplant team wants to be confident in the fact that you are able to rehabilitate yourself after surgery. Since a major part of the healing process includes proper nutrition, the team either has or will put you into contact with our nutritionist. This helps us ensure that you can get proper nutrients to promote healing and live the best quality of life as possible post-transplant. Lastly, the team needs to ensure that on top of being medically and physically ready for transplant, you have a strong support system. Social support systems should be invested in your care such that if you would need intimate care, they would be able to take you to and from the bathroom, assist you with daily living such as medication prep and meal prep, as well as be able to take you to and from the hospital. The transplant selection process reviews 4 phases of care: referral, evaluation, waitlist, and post-transplant. This is regulatory criteria, which I will review with you briefly since it's likely a review. In order to get to this educational presentation, you were referred as a transplant candidate by either a pulmonologist or your primary care physician. Once that was done, you were able to come to your initial meeting, either in person or via telehealth with our team. At this time, we were able to see if you were a good candidate for a lung transplant evaluation. You have subsequently completed the transplant evaluation process and have been deemed an appropriate candidate for lung transplant. In order to be a candidate, the team discussed your case as an interdisciplinary team. Each case is specific and discussed on a case-by-case basis. During this meeting, it is determined which type of lung transplant they think would benefit you most, whether it be a single versus a double lung transplant. Once all testing is complete and the team is at an agreement that they feel confident you would be a good candidate, you will be registered and placed on the transplant list. Patients are registered onto the UNOS National Transplant List and given a lung allocation score or an LAS score. The lung allocation score is used to determine how sick the patient is or how acute they are. In the slides ahead, we will review how your test results make up the LAS score. As a transplant candidate, several surgical factors are considered. These factors can include if you've had any infections prior to transplant, function of your right and left lungs, which will also help determine whether you need a single or double lung transplant, if there are any elevated blood pressures in your lung, which is also known as pulmonary hypertension, your general anatomy, for example, if you have any chest deformities, as well as your age and overall condition. At the University of Chicago, we are able to offer a single left lung transplant, a single right lung transplant, or a bilateral, also known as a double lung transplant. While heart and lung transplant is an option, this needs to be determined and examined on a case-by-case basis. Some disease processes that may be offered a single lung transplant includes emphysema, alpha-1 antitrypsin deficiency, pulmonary fibrosis, sarcoidosis, and retransplantation. Sometimes there may be other considerations when the team may want to retransplant a patient, but again, that goes on a case-by-case basis. Here we have a photo of an incision that would be typically made when a single lung transplant is done. Some disease processes that may be offered a bilateral sequential lung include emphysema, cystic fibrosis, bronchiectasis, and pulmonary hypertension, as well as pulmonary fibrosis. On this slide, we have a picture of a typical kind of incision that's made when a bilateral lung transplant is completed. Nationally, there are very few heart-lung transplants completed per year. A heart-lung transplant may be discussed in case-by-case scenarios where both heart and lung failure are occurring. It is important to note that the lungs will be transplanted one at a time during this surgery. During this time, you will maintain your windpipe or trachea, which is shown in the yellow in the picture. At the time of transplant, The surgeon will remove your native lung at the point just after your trachea splits into the left and right mainstem bronchi. This is represented by the red in the picture. The transplant donor lung will be reattached to the airway at that same location. This is an important site that will be monitored invasively through bronchoscopies and biopsies. The pulmonologist will ensure that the sutures will remain intact and that there's proper wound healing by doing these tests. If any issues do arise with the surgical site, the surgeon may need to go back and surgically intervene. It is important to note that while the mainstem bronchus and the major blood vessels are reattached, transplanted lungs will remain denervated. Normally, if rejection were to occur, inflammation would also occur. Pre-transplant, inflammation would cause pain. However, in a post-transplanted patient who is denervated, they would not be able to feel this pain. Instead, patients may have nonspecific symptoms like coughing or shortness of breath that need to be evaluated immediately by one of the transplant pulmonologists. As previously mentioned, the lung allocation score, or LAS, is a number that's calculated using a computer calculation. The LAS uses clinical parameters to estimate the number of days a patient would expect to live without a transplant during an additional year on the wait list, as well as expected number of days that a patient would be estimated to survive during the first year post-transplant. These two numbers are used to generate an LAS score. Organ offers are given to the sickest patients first. In LAS terms, an LAS of 0 would mean that was the healthiest person on the wait list, and a patient with a score of 100 would be the sickest person on the wait list. Generally, when patients are ready to be listed, their score will be around 30 or greater. Patients with higher numbers represent higher urgency for transplant, as well as greater potential benefit from transplant. It is important to notify your transplant team if anything such as oxygen use changes. That way, these changes can be made into the computer system, which will reflect your new LAS score. As previously mentioned, the LAS score reflects both the seriousness of each candidate's medical status prior to transplant, as well as the likelihood of a successful transplant. This slide includes the clinical information for the allocation score. The LAS criteria includes your lung diagnosis, your date of birth, your height and weight, as well as your BMI, if you have diabetes, your supplemental oxygen use, your 6-minute walk distance, your pulmonary pressures, your forced vital capacity, your serum creatinine, your New York heart functional status, your assisted ventilation if needed, your PCO2, as well as your total bilirubin. When a match is run, multiple factors are used to determine the order for making offers to lung transplant candidates. These factors include an LAS score, the ABO blood group, your HLA compatibility, your size, the distance from the donor hospital, as well as age. Lungs from pediatric and adolescent donors will be offered to pediatric and adolescent recipients first. In order to ensure the compatibility between the donor organ and the recipient, a PRA or panel of reactive antibodies is checked. This PRA is checked twice on a recipient when initial blood work is done. This helps determine if a lung transplant candidate has any preformed antibodies that could cause the body to reject the donor's organ. Your PRA is rechecked at least every 3 months while patients are on the wait list. If your PRA is greater than 10%, you may need additional treatment immediately prior to transplant. When your name is placed on the lung wait list, you will be eligible for receiving offers for all donors with negative infectious disease test results. In order to increase the amount of organs offered to you and possibly shorten your wait time on the lung transplant waitlist, the team examines all types of donors, including those with risk criteria. Some of the donors may have certain risk criteria. These criteria can include donors with risk criteria for recent HIV, hepatitis B, or hepatitis C infections. It is important to note that for these donors, due to highly sensitive testing used to identify HIV, Hep B, and Hep C in potential organ donors, the risk of transmission of undiagnosed HIV, Hep B, and Hep C infections from a donor to a recipient is extremely low. Some of the donors with risk criteria that you will be able to open yourself up to accepting once we review consent with you include donors with past exposure to hepatitis B, donors with blood test evidence of hepatitis C infections. This includes donors with active hepatitis C as well as donors with past hepatitis B infections but that are no longer actively infected. Here at University of Chicago, we do accept donors that have died due to circulatory death, also known as DCD donors. It is important to note that studies show that lungs procured from DCD donors or donors with certain risk factors have similar long-term outcomes when compared to lungs procured from donors whom have been declared deceased resulting from brain death. Considering all types of donors that are suitable for you may shorten your waiting time for a transplant. Again, please note that this is a general overview that we will go over and review with you all of these criteria in depth during your listing consent. As previously mentioned, all organ donors are evaluated for risk criteria for recent HIV, hepatitis B, or hepatitis C infections. Although the donors may have met certain risk criteria, we do not consider these organs risky, meaning the lung will not work well. A donor that meets risk criteria is an individual that has something in their history that has placed them at risk for exposure of hepatitis B virus, hepatitis C virus, or HIV within the past 30 days. The fact is that these organs are usually from younger donors with generally good health. It is important to note that for these donors, due to highly sensitive testing that is used to identify HIV, hepatitis B, and hepatitis C in potential organ donors, the risk of transmission of an undiagnosed hepatitis B, hepatitis C, or HIV infection from a donor to a recipient is extremely low. If a donor meets any of the risk criteria, you will be told this information at the time of an organ offer. At that point, you can choose to accept the organ or decline the organ. Declining an organ will not affect your placement on the waiting list. Accepting the organ from a donor that has risk criteria may shorten your time on the wait list. When a deceased donor evaluation begins, the patient's next of kin will be interviewed to obtain an extensive medical history as well as social history. If no one is available to provide this information, the donor will be determined to meet risk criteria because their medical and social history is unknown. A donor meets risk criteria if any of the following are true for them within the past 30 days. Donors who meet one or more of the following risk criteria are at risk for recent HIV, hepatitis B, and hepatitis C infections. This list of criteria includes persons who have had sex with a person who have known to have HIV, hepatitis B, or hepatitis C infections, men who have had sex with another man, people who have had sex in exchange for money or drugs, people who have had sex with a person who has had sex in exchange for money or drugs, persons who have had drug injections for non-medical reasons, persons who have had sex with a person who have injected drugs for non-medical reasons, persons who may have been incarcerated for greater than or equal to 72 consecutive hours, children breastfed by a mother with a HIV infection, children born to a mother with HIV, hepatitis B, or hepatitis C infection, as well as patients with unknown social or medical history. The risk of getting an infection from a donor that meets risk criteria is low, but not zero. Your risk of getting sick while waiting for a transplant is far, far greater. Once the procurement team identifies an appropriately matched organ for you, you will receive a call to come into the hospital. If at the time the organ falls into the risk category, the procurement team will review this organ with you. If you agree to accept the organ, then you will come into the hospital at that time. At this point, this is considered a provisional yes, meaning that our surgeons will evaluate the lung at the time of the procurement at the donor hospital in order to ensure that it's acceptable quality for transplant. If the status of the lung changes and we do not think that it is the best organ for you or a good match, you will be notified and discharged home from the hospital without surgery. You will be told when to come to the hospital and when to become NPO, also known as no longer eating anything or drinking anything by mouth. The team will also notify you about what meds are still safe to take prior to surgery. Once you're in the hospital, the team will establish an IV, get a chest x-ray, as well as an EKG or electrocardiogram, obtain a COVID swab, and get basic labs and tests. And at that point, you will meet some of the members of the team that will be involved during your surgery, including anesthesia as well as the cardiothoracic surgeons. Upon entering the OR, it is good to know that we will begin to instill medications into you. These medications include antibiotics and immunosuppressant drugs, including Similac, mycophenolate, and methylprednisone. Once you are out of surgery, you will have multiple teams managing your care while you are in the hospital. The length of surgery can be anywhere from 6 to 8 hours. Once complete, you'll be brought back to an ICU room. Initially, you will be sedated and intubated. Within 12 to 24 hours post-transplant, we will attempt to wean the sedation to wake you up, at which time you will be extubated and your breathing tube will be removed. The type of assessments that the teams will be managing during your stay include fluid management, hemodynamic management, such as measuring your blood pressure and oxygen sats as well as heart rate, your pain control, ensuring you receive adequate hydration, as well as nutrition. Please note that for nutrition, a feeding tube may need to be placed to ensure that you're getting adequate nutrition. During the pre-op, intra-op, and post-op phases, we may need to use additional machines to support you. These machines may include ECMO and cardiopulmonary bypass, aka a machine that will help you support your lungs and heart. In order to fully recover the lungs, the team will place 2 chest tubes on both the left and the right side. A Jackson-Pratt bulb drainage system will also be placed, which is typically placed near the center chest bone. A Foley catheter will be in place, which is a device that's used to accurately measure your urine and can help the team determine if you're responding properly to diuretics. You can also expect daily weights to be performed, as well as daily or frequent labs. In order to hemodynamically monitor you, the team will use an electrocardiogram, monitor your blood pressure on both your arm as well as invasively through a catheter in your wrist. While in the operating room, machines will be used to warm you to ensure that you don't become hypothermic or too cold, which decreases your body's oxygen demand. And, if necessary, medications will be used to either raise or lower your blood pressure. Patients will also come out of the OR with a pulmonary artery catheter, which is a large IV inserted to the internal jugular vein in the neck, which goes through the heart into the lungs to measure blood pressure in the lungs and tells us how the heart and lungs are functioning. It is important to know that post-operatively, as we wean sedation and wake you up, you are extubated or the breathing tube will be removed. You, as the patient, will help recuperate the lungs and open them up. This is essential to prevent post-op complications. We determine stability by drawing labs such as blood gases, which are a measurement of your oxygen, monitor and adjust vent settings accordingly, and use additional support such as cardiopulmonary bypass and/or medications like nitric oxide as necessary. There are multiple ways to manage pain. Initially, it will be managed via IV medication. Postoperatively, after being extubated, moving around, and determining your GI system has resumed normal function, we can transition these pain medications from IV to taking them by mouth. If necessary, we have the opportunity to use our pain service, as well as a PCA pump or patient-controlled analgesic pump, or even insert an epidural to control your pain. As previously mentioned, nutrition is key for a successful transplant. Preoperatively, the team wants to ensure you have met your goal weight and goal BMI. For transplant, the ideal BMI is greater than 20 and less than 30, ideally being less than 25. As previously mentioned, our nutritionist Mary Ellen, whom you may have met pre-transplant with already, will be a part of your care. Should you encounter a complication such as the bowel not waking up postoperatively, also known as an ileus, or swallowing problems, also known as dysphagia, assistive devices may be placed in order to support your nutrition. This is also known as an NG tube, which goes through your mouth into your stomach, or a G tube, which may be more permanent. A G tube would be placed in your abdominal area. Should you encounter nausea and vomiting throughout your postoperative stay, medications may be used to help alleviate your symptoms. Some of the possible complications that may occur include postoperative bleeding, which would result in returning to the OR, prolonged ventilation, meaning we would not be able to extubate or remove that breathing tube after the 12 to 24 hours postoperatively. This may result in the team needing to convert your airway into a tracheostomy or a trach. Tracheostomies can both be reversible or lifelong, depending on your status. Airway complications can also occur, such as anastomosis dehiscence, meaning the site where the newly attached lungs were connected becomes detached. Buildup of granulation tissue can also occur. This means too much scar tissue builds up, so much so that it begins to occlude your airway. Both situations would require a surgical intervention. Another complication could be a mucus plug, where you can't clear your secretions, infection, or rejection. Lung reperfusion injury could also occur. This is when air or fluid is reintroduced into a collapsed lung and the lung reinflates. At this time, some damage may have been done. This is determined after all other sources of complications have been ruled out. In some cases, patients may need hemodialysis. This is due to the fact that the blood vessels in the kidney are one of the smallest working units in the body. If the blood pressure drops during your surgery, the body's fight or flight response kicks in and perfuses blood to our most essential organs, which are our brain and our lungs. This means that there is a chance that those blood vessels in your kidneys are not getting what they need and may be damaged. Postoperatively, this is why your kidney function is monitored very closely throughout your stay. If there is an issue, you may need to support your kidneys via a dialysis machine, which requires a catheter, which is oftentimes placed in your leg. This can both be short-term as well as long-term. While in the OR, your lungs will have an ischemic time. Organ ischemic time is the time that your lungs are out of the body, not hooked up to a perfusion machine. This time can be up to 6 hours. The shorter the ischemic time for your lungs, the better short and long-term outcomes are for you as a patient. Other events that may occur in the OR include hypotension or a drop in your blood pressure, the use of a cardiopulmonary bypass, which is a heart-lung machine discussed earlier, and arrhythmias, or irregular heartbeats. We check this throughout your hospital stay by keeping you on heart monitors at all times. The way we assess for bleeding is to monitor your blood pressure, chest tube output, as well as your blood work. If you do require blood products, the team will infuse leukocyte-reduced products. This helps the body for sensitization or when your body reacts to someone else's body. All products are also cytomegalovirus-free or CMV-free. As previously mentioned, 2 chest tubes will be placed on both the right side and the left side. The purpose of the chest tubes is so that we can ensure the stability of your lungs. The staff will frequently assess the chest tubes, ensuring the correct pressure in the lungs by checking for air leaks and monitoring for bleeding by checking the drainage. When you are ventilated after surgery or have that breathing tube in, the team will frequently be checking the settings of your machine, trying to wean you off until we feel confident in the fact that you are able to breathe on your own. The team will be drawing blood gases or ABGs to ensure that proper oxygenation is occurring inside of your body. This test is another way we determine the settings of your ventilator and eventually have you breathing on your own. In some cases, after you are extubated, you may need to be re-intubated. Phrenic nerve injury may occur. At the site of your surgical incision, close by lies a nerve. Injury to this nerve can be related to post-op pressure being put on this nerve. Oftentimes, this is only temporary, however, sometimes this can be permanent. Permanent damage can cause paralysis of the diaphragm, which doesn't allow the bottom lobe of your lung to fully open up. Atelectasis can also occur. Atelectasis refers to the working units of your lung, which are tiny air sacs called alveoli. If negative pressure isn't reestablished postoperatively, then this can cause the alveoli to collapse. This can be seen via chest x-ray. In order to prevent this from happening, the team stresses the importance of mobilizing you as soon as possible. We want to give you moving, being active in your care, and doing the necessary breathing exercises. We also need you to be participating with physical therapy to finally establish that pressure that is needed. A list of infections that can occur include bacterial, viral, protozoal, and fungal. I will go into further detail on the next few slides about these. A source of bacterial infections can be the donor. Multiple swabs and cultures are taken from the deceased donor. These sites can include, but are not limited to, the skin, mucous membranes, and blood. These cultures are taken from the patient and closely followed. If any swab were to come up as positive, or one of these cultures was found to be growing bacteria, our team would be notified and your meds would be adjusted accordingly. At that time, infectious disease would be consulted. In some cases, viral infections can be present. We will monitor you for all viruses. This includes community-acquired viruses as well as donor sources. 2 viruses we are typically concerned about are CMV and the reactivation of herpes simplex virus. If you have not been exposed to CMV prior to surgery and the donor has, we will extend the duration of your meds, including your antivirals. We will also monitor your blood work more closely once these meds are completed. We treat recipients prophylactically with IV ganciclovir or oral Valtrex based on the risk of developing CMV. This treatment will last for up to 12 months post-transplant with close monitoring for CMV infection lifelong. Protozoal infections such as PJP can occur post-transplant. In order to prevent you from acquiring pneumocystis jirovecii pneumonia or PJP, we prophylactically put you on medications. All medications with these type of infections are treated with Bactrim, Dapsone, or atovaquone. The thing to know about this is, like your immunosuppression drugs, you will be on these medications for the rest of your life. Fungal infections can occur when you have a weakened immune system. Common sources of fungus include moldy basements, areas of your home where leaks can occur, as well as mulch. These sources we ask you to avoid and stay away from post-transplant so that fungal infections can be prevented. Once transplanted, you will be given amphotericin nebs for the first month or up until the point you have had your 1-month bronchoscopy. This is to ensure your anastomosis sites are well healed. Once this is completed, you will be treated with itraconazole for 6 months post-transplant. Rejection can occur at any time post-transplant. Rejection can be classified as hyperacute, acute, chronic, and acute on chronic. Hyperacute rejection occurs at the time that the lung is transplanted. Acute rejection is one thing that we look for when doing surveillance bronchoscopies after transplant. One of the ways that acute rejection can present itself would be with symptoms of a cold or other respiratory tract infections. If these symptoms are present, the team will treat you with IV steroids as well as a prednisone taper. Should acute rejection occur, changes will also be made to a patient's immunosuppression medication regimen. Chronic rejection is unfortunately common after lung transplant and is a major factor limiting long-term life expectancy after a lung transplant. At 5 years post-transplant, slightly less than half of lung transplant recipients have evidence of chronic rejection. This is diagnosed based on changes in breathing tests, also known as spirometry, and is treated with oral or IV medications and possibly with other interventions like photopheresis. Hyperacute rejection occurs at the time that the lung is transplanted, although the risk of this is incredibly low since we test for anti-HLA antibodies, or PRA. If this should occur, the treatment is IV steroids and ventilatory support. For acute rejection, it can be both cellular and antibody mediated. Acute rejection is one thing that the team looks for when doing surveillance bronchoscopies after transplant. As previously mentioned, chronic rejection is unfortunately common after lung transplant. One of the treatments for this would be to adjust your immunosuppressant drugs post-transplant. Additionally, the team can use photopheresis or plasmapheresis. This is where your blood is extracted from your body, put through pheresis machines, then re-injected back into your body to rid or lower the amount of antibodies present in your body. This slide addresses the team members that will be a part of your discharge planning. They include the post-lung transplant coordinators, social services, your floor nurses, insurance case managers, as well as your family members and social support who will be key in your discharge education. It is important to note that while it is always our goal that you will be strong enough to be able to be discharged home to your social support, that some patients do need more time as well as more help to get strong enough to return home after transplant. In these scenarios, patients may be discharged to acute rehabs rather than directly home. The inpatient team will determine if acute rehab is something that will be a part of your lung transplant journey. Therapies such as physical therapy and occupational therapy begin while you are in the hospital and may continue in the outpatient setting. Some services that will be coming to see you once you are discharged home include nursing or home health, the durable medical equipment team, pharmacy, physical therapy, and occupational therapy. Transplant, there are 3 categories of meds that you will be on for life. These include anti-rejection meds, anti-infective meds, as well as any other medications prescribed by your doctor. Key things to know about your medications include immunosuppressants need to be taken every day for the rest of your life. Many of the side effects from the medications are possible, but each patient may experience them differently. Do not adjust or miss any doses of your medications. Talk with your doctor or pharmacist before taking any new medications, including over-the-counter medications. Check beforehand when your prescriptions are going to run out, and talk with your pharmacist, doctor, or coordinator about the side effects that you may be having from the medications. Over the next few slides, I will review some medications that you can familiarize yourself with. To begin, we will go over anti-rejection drugs. These include tacrolimus or Prograf, cyclosporin or Nerol, azathioprine, also known as Imuran or Cellcept, prednisone, and Simulect. Prograf or tacrolimus will be taken every 12 hours. It is key that you do not miss any doses. If you should miss a dose, it is important to call us right away. We will let you know when to get an additional set of labs. Azathioprine or Imuran will be given daily. In the hospital, it will be given as an IV. In outpatient, it will be given as tablets. Cellcept or mycophenolate is another drug that you will be taking every 12 hours. Simulect is a drug that will be given in 2 divided doses, once in the OR and then once 3 to 4 days after your operation. Prednisone is probably a drug that you already are familiar with. Post-operatively, you will take this daily at home. Some of the anti-infective medications include antifungals, antivirals, and antibacterials. These medications are in the upcoming slides and are discussed in great detail. To save on time, I will let you review the medications briefly, and you can review them further in your education packet. It is important to note that when you are discharged home from the hospital, you will review these medications as well as their dosages, and these slides are just being used to familiarize yourself with the names and uses of the drugs. In addition to the medications just reviewed, after transplant, you will require supplemental medications. The list of medications varies between patients, but for the sake of this video, I will review them all. The main medications include medications to prevent GERD, such as Prevacid or Pepcid, medications for pain control, such as Vicodin or Percocet, medications that prevent constipation, such as Colace, medications to prevent issues with your heart rate or blood pressure, such as Cardizem. And insulin use varies between patients, however, there does tend to be a requirement for insulin related to your high-dose steroid use. Because of post-transplant patients being on high amounts of immunosuppressive and anti-rejection drugs immediately post-transplant patients' bodies' ability to fight off infections will be extremely low. Because of this reason, we want to ensure that members of the family are maintaining COVID precautions not only before patients are transplanted, but especially after transplant. Evidence shows that the incubation period for COVID-19 is approximately 5 to 6 days, but could be up to 14 days. Because of this, we are strongly recommending for our patients' social support and families to quarantine prior to visiting loved ones, as well as limiting the amount of visitors. For those who do visit, it is essential to ensure that social distancing precautions are maintained and that all people continue mask wearing. We are also recommending that everyone get their COVID-19 vaccination whenever available. Lastly, it is essential that if someone has been around any sick contacts or anyone that has any symptoms, that they do not visit. A great substitute for any in-person visitation would be a video visit or a Zoom. For our pre-lung transplant patients on the wait list, it is important to note that if a patient becomes COVID positive while on the wait list, they will be removed from the wait list until we get 2 negative COVID results. Some of the home monitoring that will be required of you once you are discharged home includes checking your blood pressure, temperature, weight, and spirometry daily, as well as recording those results. We ask that you bring this log of results to each clinic visit so that we can review the results with the physician. If you ever have any concerns about the results, you should call the coordinator or the physician immediately. Some of the home monitoring that will be required of you once you are discharged home includes checking your blood pressure, temperature, weight, and spirometry daily, as well as recording those results. We ask that you bring this log of results to each clinic visit so that we can review the results with the physician. If you ever have any concerns about the results, you should call the coordinator or the physician immediately. We would also like you to notify your transplant team if you see a drop in your spirometry measurement, have dizziness, excessive weakness or fatigue, have vomiting or diarrhea, or are showing signs of respiratory infection including cough, sputum that is discolored, or any increase in production of sputum. We would also like you to contact us at any time if you have any major questions or concerns. It is key to maintain adequate nutrition post-transplant. This means maintaining ideal body weight, avoiding alcohol, washing fresh fruits and vegetables with lemon juice solution, avoiding fruits and veggies in public places such as restaurants, especially buffets, and at family parties. We say this because you do not know how these items are cleaned. If they were not cleaned properly, they can harbor bacteria, and that can be harmful to you. We ask that you avoid grapefruit and pomegranate juice, as these can interact with the way your medications break down, making them less effective. And we also ask that you avoid all raw seafood or rare meat. This means trying to keep your meat, cooking it to medium or medium well to avoid harmful bacteria. We want you to keep exercising postoperatively. Some suggestions include walking and climbing stairs at a comfortable pace and increasing your activity each day. About 1 month after surgery, we will have you restart pulmonary rehab. It is important to avoid contact sports at all times. This includes football, karate, and skydiving. For the first month after surgery, we ask that you avoid tub baths. You should also be checking your incision daily. Please avoid crowds, restaurants, stores, theaters, or other large gathering places. Avoid construction areas as they are largely populated with dust. Do not drive the first 6 weeks, and do not lift anything greater than 10 pounds. Please note that this weight is a little larger than a gallon of milk. Once you are 6 weeks out of surgery, we ask that you wear a mask when going out, such as going to the hospital or the clinic. You may also sleep with your partner and resume normal sexual activity, but ensure to avoid any strain at your incision site. Other precautions include do not swim in any stagnant bodies of water as they may be harboring bacteria. You can, however, swim in chlorinated pools after the first 6 weeks. You need to wear a mask and gloves when gardening, but make sure that you do not mulch. Wear shoes outside to prevent any infections on your feet, and also wear sunscreen when you are in the sun. Please note that you should never be attempting to suntan in a tanning spa. The immunosuppression drugs that you are on will cause you to have a weakened immune system. We ask that you avoid people with contagious illnesses such as colds, flu, cough, runny nose, or chickenpox. You avoid any sick children. You do not change any baby diapers, and you wear a mask when going outside on windy days. We also ask that you avoid any fresh salads in restaurants. Clean and bandage any cuts, and report any signs and symptoms such as infection, redness, drainage, warmth, pain, or swelling to your physician. Other precautions include not wearing false fingernails or tips as they can cause fungal infections, speaking with your doctor or coordinator before any dental or surgical procedure as you may need antibiotics, ensuring any current pets are checked by the vet and making sure that they are up to date on their vaccines, and never changing any kitty litter or birdcage paper. What to expect as a newly discharged transplant patient is weekly visits for the first 4 weeks, accompanied by weekly blood work for the first 4 weeks as a post-op patient, a bronchoscopy and lung biopsy at weeks 1, 3, 6, 9, and 12 postoperatively. Once you are discharged home from the hospital, you will still be recovering. Our policy is that if you live 2 to 2.5 hours away or longer from the hospital, you will need to remain in the Chicagoland area for 2 to 4 weeks or longer, depending on your progress. This is so that proper follow-up care can be taken. The social work can provide you with resources, and the financial coordinator can determine if there are any monetary benefits available for you. As previously mentioned, social support is a key aspect in a successful transplant. Transplant patients are not candidates alone. A family support system is required. It is important to ensure that individuals are taken care of so that the team remains intact. We offer a lung transplant support group, which you and your support system will be invited to. Another option for support includes an online support group. Lastly, it is important to understand transplant is a lifelong process and we are developing a lifelong relationship. In order for that relationship to be successful, clear, open communication is essential from both you as the patient as well as your transplant team. By having this, we can expect the best possible outcomes for you. Thank you for listening. This concludes our presentation. Your pre-nurse coordinator will be in touch with you shortly to answer any questions you may have about the presentation. On this slide, you will find the contact information for your transplant nurse coordinators. Thank you.